Well, welcome back, everyone. Caitlin and I are excited to be here with you. And we have a topic that I think will be near and dear to many of you listening in, and that's going to be related to falls. Now, we are changing up the structure of at least some of our podcasts. We're going to make them a little bit shorter. And I think that's because I just think about myself and my attention span. It's not real long anymore. And then with kids, I think it's gotten even shorter. So, we want to make these to be podcasts that are fruitful for you to listen to, that you can gain things from, that are actionable for you to put into practice. And today is one of those very podcasts where we talk about the topic of falls. And this one, to me, I was telling Caitlin this before we got on, is really near and dear to me. Those of you that are listening in, you probably do not know this, but my mother herself has Parkinson's disease, and it's been a wild ride. She's progressed quite a bit this year. In fact, is having some of the Parkinson's disease psychosis and other things like that. But we did a little stint here recently where she fell about 5 times in like less than 2 weeks and ended up in the hospital. In the hospital, she did some rehab, then went out to a rehab swing bed, and now she is still doing rehab in a long term care facility, and falls are becoming a part of her kind of norm, and we're just trying to figure out how to minimize those from being ones that are really going to make her take a turn for the worse. And I think for you guys listening in, if you are a nurse or if you're an administrator, pharmacist, whatever, you have likely seen an elderly patient that you were taking care of in your facility, and they took a bad fall, and it just, their whole level of care and their whole trajectory that they were on went completely south. And that is what we're trying to prevent today. Really, the goal that Caitlin and I were talking about before we get into this is that if you listening in walk away saying, let me look at their medications, or let me have the consultant pharmacist look at their medications a little bit closer, that's what our hope is. Because whereas not every fall is related to meds, we're going to talk about some scenarios where it may be. So we want to throw that out there as the main goal that we're wanting to accomplish. Now, as we get into this, Caitlin and I want to talk about 6 drug classes that are most strongly associated to falls that are in long-term care. And so, Caitlin, why don't you kick us off with the first drug class on the list?
Antipsychotics.
Of course, our big
Mm.
antipsychotic players, and we
Yep.
see these a lot. And in fact, that is why there's been so many initiatives, I think, in long-term care. Obviously, we want people to have quality of life and not be completely passed out on an antipsychotic and all the side effects that come with them. But um, they're used for a lot of different conditions. And unfortunately, fortunately, I guess, they are useful in a lot of conditions, but with the side effect profile strongly heavily leaning towards dizziness and drowsiness and things that can cause falls easily, it's the number one on the list for sure.
Yeah.
What's next after that?
Benzos.
Our friendly benzos. Um,
Mhm.
and I will tell you, this, we see this a lot, right? Where um, people have maybe been using those throughout their lives and they've kind of become dependent upon a benzo or whatever. And we want this to be made known because every patient is a little bit different, right? You might have somebody that is on an antipsychotic and they're not falling. And you might have
Right,
somebody that's on a benzo and they're not falling. But then you might
right.
have somebody that's recently started on an antipsychotic or a benzo that hasn't been on it a while. Their body is not really used to it yet, and they are falling. Um, those may be the patients that you're really thinking of right now as you're listening into these. But even the ones that have been on it a while, we're going to talk about in a second how our bodies change over time. And because of that, these are the classes that can cause the side effects. So definitely benzodiazepines. The third one, not gonna be a shocker here either. Caitlin, what's that?
Antidepressants.
Yeah, antidepressants. So you're gonna notice a trend here that the first 3 classes, and even, well, I guess you could even say first 4 classes really could be things that are all related to mood and psych.
Mm,
And they all carry um, their own risks associated with them. And I think, Caitlin, you mentioned this, that not every drug is without its risks, right? Even
right.
antibiotics and things like
Yep.
that. And so as we are breaking these down, these shouldn't, come as any shock that where they do have benefit, they do have the risk of falls and things like that associated with them. So our antidepressants, our SSRIs, SNRIs, you name it, they all pretty much have that same risk of drowsiness, falls, things that can come from them. What's next on our list?
Anticonvulsants.
Yeah, so we see anticonvulsants quite a bit, and it can be related to seizures, absolutely, and that's their original intention.
Yep.
But we see them oftentimes for what, Caitlin?
Mood.
Yeah, mood
Mood.
stabilizers
Mhm.
are what we see them now for primarily, whether that's the Depakotes of the world or the Lamictals or whatever you want to go with.
Right.
We see those quite a bit. CMS is also focused on the fact that they're being used for mood stabilizers. And again, whereas it might be advantageous for a resident to get off of that and switch to an anticonvulsant, like off of an antipsychotic, get on an anticonvulsant for mood, they don't come without their own set of risks. And
Exactly.
so the next one on the list is antihypertensives.
Mhm.
We don't see very many antihypertensives in long-term care.
No, the list is very short.
Yeah, just a few
Yeah.
patients here and there.
Yeah, that's a
Um,
lot.
it's a lot, and we
It
get,
is.
when we're looking at, antihypertensive residents, as consultant pharmacists, it's a rather robust amount of patients in that building that
Yeah.
are on antihypertensive drugs, and,
Yep.
so again, not without their own risks, do have benefits, absolutely. But blood pressure related falls and things are absolutely something that can happen. And the final class, number 6, is what, Caitlin?
Hypoglycemic agents.
So those are our insulins, our sulfonylureas, and,
Yep.
obviously blood glucose plays an absolute role in falls. And so when you put all these together, you're seeing that the fall risk is increased because these classes, specifically these 6, have increased sedation, um, hypertension, hypotension, different things like that that can happen, hypoglycemia, impaired balance due to the dizziness, drowsiness of the drug classes, etc. Again, can be very useful for conditions, but obviously, with the pros that come from them, there are definite risks that we have to consider. And so, Caitlin, I want you to talk to everybody listening on here about the different reasons why maybe like the 3 areas that we see, especially in our vulnerable long-term care population, our elderly population, as to why maybe even having been on these for a long time and they're still falling or they're now starting to fall, or what's going on in their bodies that might help people understand why drugs do play a role in everything.
Yeah, so the first one I wanna bring up is the change of our bodies as we get older. So their pharmacokinetics are gonna change. Their liver metabolism, their kidney metabolism, it can slow, it can also cause more absorption or less absorption, and then also just the natural chemical breakdown of the bodies as we're getting older. So that can cause like an offset of chemical imbalances that maybe we didn't see so much before when we were younger. There are some drugs that have to be through the liver that get converted to the active ingredient. You may see a little bit more of that, you may see a little bit less of that, and some inactive ingredients that get converted at a higher rate in the liver cause side effects. So, with these types of imbalances, as our body gets older, we do see that increase in sensitivity in our elderly population of how these drugs affect them. A good example is antidepressants like the serotonin. They're more sensitive to that buildup. Whereas when we are a little bit younger, our bodies are able to eliminate that excessive serotonin, whereas when we're older, they don't eliminate it as well. So they're at increased risk of anxiety, jitteriness, insomnia from that class of drugs that's already listed as a warning, but they're at a higher risk of those things. So that's number one. The other one is polypharmacy. So we notice in 65 and older that we have to take or we see more medications being on board to regulate our bodies. Something's not working exactly right, like hypertensive agents. So our blood pressure isn't as well regulated naturally on its own. So we may see rather than just one agent, three agents to make it that perfect number. Well, with that comes higher risk of those side effects of my blood pressure was way up here when I lay down, and as I lay down, it dropped, and then when I get up, I'm dizzy, right? So, polypharmacy is a big topic in this population of having those multiple meds on board with the increased side effect profile that they're already at higher risk of experiencing. Another one is their conjugative impairment. So, this is why we really want to be low dose, most effective dose at the lowest. So it kind of will help us, understand that the lower the dose, the better, and also like decreasing the risk of side effects. But they already have an existing impairment that these certain drugs coming on top of that make worse by accident. Like, once again, with all the other examples, we're trying to regulate something but we're tipping it in another way by accident because of the side effect profile that these drugs already carry.
Right. And I think it's really important to know those 3, and you guys listening in understand those 3. You might not have understood as much of the pharmacokinetic and dynamic changes that happen where we see the renal function, kidney function, like Caitlin was saying, as well as the dynamic changes where they just become more sensitive to drugs over time. But the other 2, having a lot of drugs that are being used to treat, I mean, the more drugs, the more side effects that we're gonna see for that person. And then like she was saying, the cognitive impairment, the frailty of the person. And when we're looking at falls, uh, I looked at one the other day, and not all of them appear at first to be med related and may not be med related. For example, sometimes you just see the ones where they're leaning over to grab something out of their side table and they fall out of the bed. So, is that med related? Probably not most of the times. They're just getting it, they lose their balance, whatever, lean a little bit too far, don't have the strength to like in the core to be able to pull themselves up like you or I would have. But it could be med related if that person before was not dizzy. We started them on a drug. Maybe it was an antihypertensive, maybe it was a benzodiazepine, whatever. They go to lean over and
Right.
now they were fine before, but now they're
Yeah.
falling. And so again, that's where it helps to have us come in. We'll talk about that here in just a second. We came up with just like 5 quick questions that you guys could think of that are listening in to almost like a kind of a micro assessment, so to speak, to determine
Hmm.
in your mind, well, does this sound like this could be med related, or is this a possibility for med related? So one of the first questions would be, has there been a recent dose change at all for this person? And we know that in long-term care, there are a lot of dose changes that are happening quite often for our patient population that we're taking care of. So what dose changes have occurred? And was it in one of those 6 classes that we talked about, or just in general, was there a dose change of anything that happened? Another one might just be something like, was there any dizziness? Was there any confusion? Was there any sedation that the person experienced? Those are really good keywords to remember: sedation, dizziness, confusion, because those can be med related. Can be, the confusion can definitely be um, disease state related, like could be a dementia resident or something like that. But if it's another resident, or maybe there's increased confusion even in a dementia resident, then that would be a red flag that it might be med related. Are there
Yeah.
any PRN psych meds? And we see these given all the time. Not antipsychotics, but we see benzodiazepines given.
Right.
We
Or even
see,
opioids.
yeah, opioids,
Opioids
or
are a good one.
Yeah, that's a
that
huge
can
one
cause
there,
that.
which
Yeah,
isn't on our list of the top 6, but it absolutely would be
it
right up
can.
there on
Mhm.
those, because of the side effect profiles of them.
Yeah.
But, have there been any PRN meds that have been given in the last 24 hours or in and around the time frame of the fall? And if the answer to that is yes, then that's a good telltale sign that we need to look at their meds and make sure that that wasn't what increased that dizziness, drowsiness, or confusion or something that caused them to fall. Any blood pressure readings that are low, so less than 110, having hypotension, low blood pressure can increase your risk, and we're talking about
Mhm.
systolic there for the 110, can increase your risk for falls. So has that occurred? And then obviously we mentioned blood glucose originally. Any low blood glucose readings, that again is another good red flag of like, okay, well, what can we do to make changes to their regimen or to their medication regimen related to the diabetes to decrease their risk of fall? And in this setting, we're really trying to prevent hypo and hyperglycemia. That's the main goal, according to ADA, for this
Mhm.
population. So, how can we do that? How can we accomplish that? And maybe we need to kind of lower some of the regimen, how much we're giving them, so that it lessens the risk of hypoglycemia. So, again, recent dose changes, any dizziness, drowsiness, confusion, sedation, any PRN meds given around the fall or within the last 24 hours, any low blood pressure or any low blood glucose values. Those are all a quick 5 question thing to ask yourself as a nurse if you're taking care of somebody, or even as a pharmacist that's assessing that resident for falls. Did any of these things occur? And if so, then that could be a med related cause, or meds could be playing a role in that fall if it's not the main cause. And so I think what Caitlin and I want to leave you guys with is obviously we are here as pharmacists to help and to assist as you are having residents that are falling. I mean, Caitlin, you just said you reviewed one
Mhm.
yesterday, I think it
Yeah.
was.
Yeah.
And so we get these quite frequently where homes reach out to us and say, "This person's falling." Quite often, is there anything that you think could be changed on that? So, some takeaways for this is just again, as you've listened to this, knowing that yes, they're frail and elderly. Yes, disease states play a role in that. Falls are multifactorial. It's not just one thing. There can be a lot of things that are causing falls. But what we want you to really grasp is that meds can also be something that is playing a role in that fall. So, thinking through this, what are some things, Caitlin, that if they're seeing this in the homes, they could
Mhm.
reach out to us to have a med review done?
One thing is sudden change of behavior. So I think that's a big one. Um, Increased falls from baseline. Another one could be if maybe they're not falling a lot, but they're adding several CNS agents on board and a fall or increased fall risk is coming, and they want to just make sure that we're doing the right thing or if there's a way to limit or other therapeutic options. And then obviously any type of change of condition. So whether it's like, hey, this regimen was working, now we're going hypo all the time, like what do you suggest? Or, now this patient's having hypotensive episodes, what do you suggest? Things like that. Even some of this could be preventative before falls come about. Or sometimes it is the fall that triggers them to ask pharmacists to come in and look at the medication regimen.
Yeah, and all those are perfect. And so as you're listening into this and as we are wrapping up, we want you to know that we're here. We are wanting to support you as part of the interdisciplinary team taking care of these residents. And we want you to walk away knowing that falls are multifactorial, but meds can play a role. Let us help you evaluate those medicines and make sure that they're appropriate for that person, and that person is not suffering from more of the risks of the med than the benefits of the med, so that we can try to get a reduction of those falls. we know that this is a big topic for you, and we know that there's many other big topics that you have in the long-term care space. We want to hear from you. Caitlin and I are always available for feedback. And so we have our info in the show notes so you can reach out to us directly if there's something that you want to hear about. And we just appreciate all of the support, all of the community that is kind of rallying behind listening to these podcasts. And we look forward to bringing you more. And with that, we're going to sign off of here, make it a quick podcast. Hopefully, you've learned quite a bit from this in a short amount of time. And we look forward to another podcast here pretty soon. Bye, guys.